Hi, I'm Dr. Archana Sarda in Aurangabad, and today I have done something very different I've never done before. Today I picked up Dr. Ajit Bhagwat, who is a very senior cardiologist in Aurangabad, and we are traveling across Aurangabad, all the historical and beautiful places, and discussing science. I really find this concept very interesting, where we are part of the historic and travel of a city, yet talking about science which is so close to our hearts. So this science really comes together as Metabolic Roadinar, and a CME on the roads is what I would call it.
Aurangabad. Earlier, the city was known as Khadki. This place is popular for its Himru textile and the Paithani silk saris. Also, Aurangabad is one of the most visited tourist destinations in Maharashtra. Attractions such as Ajanta Ellora caves and Bibi Ka Maqbara attract several million visitors out here. And what's more interesting about this city? Well, it's got 52 gates that were built during the Mughal era. And even today, we call Aurangabad the city of gates. And when we speak of the Mughal Empire, history will remind us of the Maratha Empire and its legacy. Today, two top KOLs from Aurangabad, Dr. Ajit Bhagwat and Dr. Archana Sarda, are visiting the Suneri Mahal. That's a testimony of the unique craftsmanship and Indian architecture. Later, they visit the Bibi Ka Maqbara, a historic monument that symbolizes the love of the Mughal Emperor Aurangzeb for his wife Dilraz Banu Begum. Finally, they end their day at the Aurangabad caves. So without wasting further time, let's join their exploration and be a part of the medical science and conversation.
Dr. Ajit, it's so nice, such pleasant at Suneri Mahal in the university today. Do you come here often?
Well, on weekends, yes, we do. We come here on weekends. I've never been to this place for, it's almost a couple of years before that I had come here. But it's a very nice place, for sure.
I remember, have you ever attended those? There used to be musical festivals here.
Yes. Actually, this has got a great historical context. Actually, this was built in 17th century, when Aurangzeb was here as the Subedar of Deccan.
Okay.
And one of his colleagues built this, and at that time it cost him about 50,000 rupees.
Okay.
So this is an historic place, and as you said, inside this there are sprawling gardens. There is a ground inside, and they used to conduct musical shows every year. With stalwarts of music, big stalwarts used to come here, but because of this COVID and pandemic,
we're missing all that.
Yeah.
Speaking of pandemic, sir, we are now having so many patients. I just wanted to ask you, last few years, another thing which we are seeing is the whole awareness in I practice only diabetes. So my patients, I was always not that conscious of heart failure. But with all the 5 years of new data coming in and so much of experience, so that heart failure patients are rising, we are more conscious. So do you think the numbers are rising, or now that it's getting picked up, we're talking about preserved ejection fraction, reduced ejection fraction?
Well, it's both. We are more aware that heart disease exists more in diabetics, and second thing, it's detected more often, and the prevalence of diabetes, you know diabetes more than me. India is the hub of world diabetes, so that's very important. So sheer numbers. So if you really look at heart disease patients, almost 30 to 40% have diabetes, almost 30 to 40%.
And I was going through data, so that 30 to 40% of patients with diabetes have heart failure.
Exactly.
I mean,
So
that was really alarming.
and it's unfortunately many times it's unrecognized, and it is not addressed properly,
Right.
and that's the problem. See, whenever I see a patient in my clinic who has diabetes, my antennas are up simply because I know that this gentleman is going to have disease involving multiple vessels.
Right.
He may have diffuse coronary artery disease. Sometimes these patients have bad kidney function associated with it, and overall this subset is different and more complex.
And
than
amongst that, sir, the cardiovascular disease and the stroke, amongst that, even more than that, we are seeing heart failure. So this was something I was not
Exactly.
aware of, say, 10 years back, and detecting it early enough. And the outcomes are
the outcomes are far worse as compared to people who do not have diabetes.
do not have diabetes.
And the reason for this is again multifold. One is it is not detected, and by the time they reach the doctor, it's quite late. Many times they have myocardial infarctions which go undetected because quite often they don't have symptoms. They are unrecognized, and that is not uncommon.
True.
So these are the factors, and then heart failure, as you said, is something which is a sign of advanced heart disease. Before heart failure develops, they have coronary artery disease,
Right.
And then because of diffuse disease, multi-vessel disease, sometimes they develop what they call a diabetic cardiomyopathy. So in diabetes involving microvasculature of the heart and producing left ventricular dysfunction. So this is a complex issue, and to make the long story short, if you see a patient of diabetes and heart disease, you are dealing with a high risk patient, much higher risk than
So I
average
think
risk.
that message is also for people like us and who are practicing diabetes specifically, that being to be very, very aware of this high risk. I mean, we're always looking at the macrovascular complications, but the focus on heart failure is not there. Early detection is not there. So that whole sensitivity.
You are absolutely right. It's not only heart disease. Many times I see patients who have been seen by doctors outside, treated their diabetes, but they have not looked at their urine protein, not looked at their fundus, not looked at serum creatinine for years.
Absolutely.
So if these three things are not seen, forget about heart. So I think one has to remember this very important fact that when you see a patient with diabetes, always look at the target organs. Yeah.
And so early detection and a high sensitivity at our end would really make a...
Absolutely. Absolutely.
And explaining to that patient would also be very important, I think.
In diabetes, the patient who knows most lives most.
Lives most.
It's not only for the doctor; it's for the patient. Patient education in diabetes is most important.
Absolutely.
I mean, diabetes is one disease where
you
the patient
can actually take care of yourself, improve your
absolutely. And if
lifespan.
you don't know much about your own disease, it can hurt you.
True.
And diabetes is one biggest example of such a disease.
So the onus is on the doctor to educate our patients.
Absolutely. And I think that is something which we are lacking in many times. For many reasons, you don't have time. There are so many patients. But then we need to evolve a system. That's not an excuse. I agree with you.
Absolutely. It is a chronic disease. They have to live with it. We want to give good outcomes. We have to educate and empower our patients. Absolutely true, sir. So looking at heart failure, going back to heart failure, I think that was something which was very underrated earlier. It was not focused upon, and I think a lot of studies when they came in, new drugs came in, because we didn't have much we could do about it. In my clinic, there was nothing I could really do about it. Now I have choices which have a common...
See, now the situation has come where the diabetologists have to know more about heart disease, and cardiologists need to know more about diabetes.
Right.
And this is because of these new drugs like SGLT2 inhibitors or GLP-1 agonists. These are the drugs which help.
Absolutely. Now our algorithms are always high risk CVD, CKD, our drug choices change. And now that we have options.
Right. And I cannot say, or a cardiologist cannot say today that, for diabetes, you have heart failure and you have diabetes, go to your diabetologist and get treated. So now I have to deal with it.
Right.
And I have a choice. I have choice of drugs which help me and to deal with such patients.
The same goes for me. I cannot say that I don't know which drug is best for you. I have to prescribe a diabetes medicine which can be complementary to their heart failure care as well.
Yeah. And the good thing about these new drugs is, they rarely cause hypoglycemia. See, as a cardiologist, I don't want to treat diabetes because I don't want to deal with, those hypoglycemic emergencies. I don't want a nighttime call, blood sugar has gone down to 20. But these are the drugs which not only control diabetes safely, but they have tremendous positive effects on cardiovascular system.
So, last week, if you remember, Mrs. Suryavanshi, I had referred to her because I was really confused. She was breathless.
Yeah. Actually, if you really talk about that patient, she had a classic heart failure with preserved ejection fraction. She was a diabetic for a long time.
Yes, she was a diabetic. She's been with me for a long time, but her 2D echo was normal.
Yeah, that's the problem. In such patients, the ejection fraction was normal.
Right.
But that doesn't mean she was not in heart failure. And that is the one important point that must be stressed. That what happens is patients come to you with breathlessness. They have long-standing diabetes, hypertension, they are obese, and you want to know why they are breathless.
Right.
And you get a 2D echo, and 2D echo shows ejection fraction of 60%. So it's there's no heart.
Happened with her, I remember.
That's right. But she was a classical case of heart failure with preserved ejection fraction.
Okay.
Now her echo was normal only as far as the ejection fraction was concerned. But if you really look at the other parameters, if you study her diastolic function properly, if you look at her left atrial size, there are some subtle signs which you have to look at.
Right.
And that can give you some clue as to what we're dealing with. And when you look at that, you can diagnose heart failure with preserved ejection fraction.
So between the two, the reduced ejection fraction and the preserved ejection fraction, is there a way we can clinically differentiate?
Well,
for me,
there are some clinical features which make you differentiate between the two.
Right.
But it's not always possible to do that. Many times patients just present with fluid retention.
Right.
They are bloated, they are breathless, they cannot lie flat on their back, they have pedal edema, they have raised jugular venous pressure.
Right.
Now, in that situation, it's very difficult to say what we're dealing with.
Right.
Now, you look at their echo, and if the echo shows reduced ejection fraction, say ejection fraction is 20%,
Correct.
then you know this is a heart failure with reduced ejection fraction.
Right.
But if their ejection fraction is normal or even more than, like 60%, 70%, they can still be in heart failure. That's the most important concept that's right. So this concept is very important, and there are ways of diagnosing it. But the most important thing is high index of suspicion.
Right.
That when you know that such patients can have heart failure.
Right. That's why I sent the patient to you.
Yeah.
I was so confused that
Right. So that patient was, she had all classical features. She had all signs of fluid retention. She had pedal edema, and she was orthopnic. So all these features of heart failure.
So would biomarkers help when there is confusion if it was not so classical?
Yes, biomarkers would definitely help. Okay. Biomarkers would definitely help. But if you are strongly suspecting heart failure with preserved ejection fraction, the biomarkers would help. If the biomarkers are raised, it tells you that patient has heart failure. But one thing to remember is biomarkers, they are important, but you cannot solely depend on them.
Okay.
Clinical features and index of suspicion is very important. So sometimes patients are given diuretics outside, sometimes their BNPs may be low because of some other factors like obesity, for example. So these are some confounding factors which you must remember.
So how would we go about for example, a person in my OPD has been diabetic for a long time, he or she.
Yeah.
So that suspicion index, yes. So clinically, 2D echo and biomarkers. So could you give me a logarithm on How would I identify?
See-
and at what stage can I detect?
Yeah, so I think who is a typical patient of heart failure with preserved ejection fraction?
Right.
The typical patient is a female who is long-standing hypertensive,
Yes.
who probably has diabetes, and now she has come to you with symptoms of breathlessness. And on examination, you know, if it's an advanced heart failure, you may see signs of
Anyhow,
fluid
you could
retention.
see that.
But you know, you may not see those signs.
Right.
So patient may not have edema, patient may not be bloated.
So what does
So in that situation, you need to, you know, in a cardiologist needs to come into the picture at this time. And then you do a detailed echo exam. And there are certain features on echo. You can do biomarkers in the situation, and that suppose in this patient you see left ventricular hypertrophy.
Right.
You know, presence of marked left ventricular hypertrophy, mildly enlarged left atrium, features of diastolic dysfunction on Doppler examination, and elevated biomarkers.
Right.
If these things are present in combination, not all, but you know, 1, 2, 3.
So it's again a judgment call.
Right.
In all these.
So when you see this, then you know you're dealing with.
So would you recommend that we do biomarkers for all, BNP, proBNP, both?
Well, doing it
For every
for
person with diabetes?
that would be an overkill.
Because I have recently seen that people are doing the kind of camps for biomarkers for people with diabetes. For high-risk patients, would you recommend that?
For high-risk patient, I would recommend it.
Okay.
You know, but I would not recommend it for everybody. That would be an overkill. You see how many patients you see every day.
Exactly. So that
So-
will just add to the list of
Yeah,
investigations.
so that's an overkill. But keeping the possibility of heart failure in these patients, particularly when they come with symptoms of breathlessness, is very important. So, Dr. Archana, SGLT2 inhibitors are in the market for last year, maybe year and a half. So, as you're a busy diabetologist, tell me about your experience with these drugs so far.
So we've been using them quite extensively, very honestly, for last 4 years or so now. And I am actually very happy. Basically, it almost seemed too good to be true when we initially thought of the glycosuric effect being actually making a difference. But now that we see it, the tangible benefit is glycemic control. And since it is not using the pathway which is already used by the other drugs, we are able to use it as a first add-on, second add-on, last add-on, and even in our patients on insulin. So we're having very good glycemic control with SGLT2 inhibitors. Other thing is weight loss. That is amazing
Important.
advantage. I mean, that's something patients are very happy with. Even if it's expensive, patients are very happy to use it, and that itself gives us so many other benefits. The BP control is
Right.
definitely enhanced with it. And with all this data coming in, now that we are seeing how good it is in heart failure, hospitalization for heart failure going down so extensively, and its cardiovascular benefit and renal benefits, I mean, all put together, it
Yes.
becomes, evidence-based as well as clinically a great drug to have. So do you have any experience with heart failure patients specifically?
Yeah, sure. You know, before I talk about it, I would like to emphasize that when I looked at the data and everything, I'm convinced that these are basically cardiovascular medicines which happen to be
Used for having
which happen to have
glycemic benefits.
glycemic benefits. You know, if you really look at the spectrum of their benefit, it's huge, right? Starting from the blood vessel to the myocardium, to the entire vascular endothelium of the body. So, which also includes kidney.
Absolutely.
So that's the important thing to remember, that it happens to be an anti-diabetic drug, but basically it looks like it's a cardiovascular drug.
True.
And my experience of using this drug is for last maybe couple of years, year and a half, because I don't treat diabetes. But then when its cardiovascular benefits started coming up, then we had to use it, and we had to learn about these drugs. And if you really look at the data in heart failure, there are 3 seminal trials Two of them are in heart failure with reduced ejection fraction, and one is with preserved ejection fraction.
Yes.
So the two with reduced ejection fraction are DAPA-HF, which is with dapagliflozin, and Emperor reduced, which is with empagliflozin. Now, actually, the results of these two trials are literally superimposable. You know, the patient
That
subset.
kind of replicities.
Yeah, so it kind of reinforces your belief in these drugs. And when you have two trials, you know, you are more safe. Yeah, coming independently about two similar drugs. Same type of patients were studied. You know, almost 3,000 to 4,000 patients in every trial. And the benefit of empagliflozin as well as dapagliflozin was seen over and above the standard treatment of heart failure, which means a beta blocker, an MRA, and ACE inhibitors together. Now we have ARNI, which is a combination of sacubitril valsartan, and the benefit of SGLT2 inhibitors was seen over and above what you use in your standard practice. So that's very important. So now you have Fab4, fabulous fours in heart failure. One is beta blockers, second is MRA, mineralocorticoid receptor inhibitors, ARNI, and SGLT2 inhibitors. And now we have come to a point where quite often when you see a diabetic patients with heart failure, we use this drug as a first drug in heart failure. So this was about heart failure with reduced ejection fraction. The benefit, the end point in both the trials was hospitalization for heart failure and mortality, combined endpoint.
Right.
And the combined endpoint was reduced by almost 20 to 25% in both the trials. So it's very important to remember. It's not only important to improve survival, it's also important to keep the patients out of the hospital.
Absolutely.
No, otherwise they keep on getting admitted to the hospital, and it's very important to do this to improve their quality of life. So both these drugs have done that to the medical fraternity's satisfaction. So that is most important to remember. And the second trial was Emperor Preserved,
Yes.
which was in patients with heart failure with preserved ejection fraction. Now, this, as far as this disease is concerned, we were really frustrated. We didn't have any.
That was the challenge.
That was what we call as the last frontier in heart failure.
We actually treated.
We have many more frontiers, but this was one of the important frontiers. And there was no drug which was making a meaningful difference in quality of life as well as survival in these patients. And SGLT2 inhibitors is the first drug which has done it to a significant extent, I would say. The benefits are not as solid as they were in heart failure with reduced ejection fraction,
Yes,
but they are certainly far better than what we had with other drugs before.
Especially, I think, symptomatic relief.
Absolutely.
Quality of life.
So symptomatic relief, quality of life,
6-minute walk test, I think.
6 minutes walk test, their ability to walk more, and ability to keep them out of hospital. It's most important. Time at home, time spent at home is very important in these patients.
And I think another very good thing about SGLT2 inhibitors is that cardiologists can prescribe it without much stress. I mean, the whole fear of hypoglycemia.
Actually, you will be able to tell it in a better fashion than me about its safety, because you use it, more than what we do. More
Absolutely,
often,
sir.
But they're fairly safe.
They're fairly safe. I think the only thing we watch out for is explaining hygiene to them, telling them to hydrate themselves adequately.
Absolutely.
And
so
it's really taken care of.
So as a cardiologist, as I mentioned earlier, that we're worried about hypoglycemia. So we don't want to prescribe insulin, prescribe sulfonylureas, which can produce hypoglycemia. So we are happier with these drugs.
Absolutely.
And important thing is you don't have to titrate these drugs. You just start 10 milligrams of either empagliflozin or dapagliflozin and forget about it.
Right.
And most often patients would not complain about the side effects.
Very good patient satisfaction we are seeing. All fronts, it really. So do you also have to titrate maybe diuretics when you are using? Because
that's an important point, because these have glycosuric effect. A lot of free water goes out with it. Right. And people who are on, say, moderate doses or high doses of diuretics, you have to be watchful. because they can get dehydrated.
Right.
And many times we can actually get rid of diuretics in many patients with heart failure
Right.
when you add SGLT2 inhibitors. So that's very important to remember.
Right.
And it's very important to remember that this is not a substitute for anything. You are not substituting any drug with this. You are adding a drug. So don't make a mistake of saying that the previous drugs were not good or inferior for heart failure specifically.
Right.
You continue to use your previous drugs, and over and above it, you use this drug.
So I think now we have something that binds us together.
Yes, as a cardiologist. That's why I said that now cardiologists can probably treat. They can say that we can treat diabetes. Yes, that's important.
Hello friends, I'm Dr. Rajiv Kovil and I'm going to talk to you about a very important data about heart failure and dapagliflozin. And today two wonderful KOLs from Aurangabad, Dr. Ajit Bhagwat and Dr. Archana Sarda, took you around Aurangabad, Bibi Ka Maqbara, so many caves, and they had a taprika chai and they spoke about DAPA and heart failure. But I'm going to summarize it for you. Now, heart failure is like an elephant in the room. Now, heart failure is twice as common in men with diabetes as compared to women. The heart failure prevalence in diabetes is close to 25 to 30%. And one data from the Lancet, I think published maybe 5 years back, which looked at the contemporary association between complications and diabetes, shows that heart failure is more common than MI and stroke. And this was an eye-opener for me, that heart failure is much more common than the macrovascular disease which we have been chasing for the last so many decades. And we need better options to treat heart failure. And a lot of our patients go into heart failure, and that's the reason that I am speaking to you to give you a take-home message on how to treat heart failure. Now, why do you need to treat heart failure? Now, heart failure survival is as poor as some kinds of infiltrating cancers. That you see that there is almost 50% mortality at the end of 5 years, which is not seen with many infiltrating cancers as well. So, the kind of importance we give to cancers, we need to give to heart failure, and make sure that we have heart failure clinics as well, and make sure that we use a lot of evidence-based management in treating heart failures. Now, when we look at staging of heart failure, it's very important that we look at the ACC 2013 staging of heart failure. So, what is it? The ACC-AHA staging of heart failure 2013 looks at stage A, where you have a absolutely structurally normal heart, but you may have diabetes, you may have blood pressure, you may also have coronary artery disease, but the heart is structurally normal. Stage B is where you have a structurally abnormal heart, which could be an LVH on echo, LVH on an ECG. Stage C is our symptomatic patients. Those are our patients who have symptoms of heart failure. Could be pedal edema, could be basal crackles, basal rals. These are stage C. And stage D are our refractive heart failure. It's very important for us that we are able to pick patients with stage B heart failure. Those are those patients who show LVH, may have microalbuminuria, may have LVH on echo or on ECG, and make sure that they do not progress to stage C heart failure, which is symptomatic. And this is where all our data comes in. We need to prevent new onset heart failure. Now, there are two types of heart failure. We have heart failure with reduced ejection fraction and heart failure with preserved ejection fraction. You have less blood coming into the left ventricle because of myocardial stiffness, and therefore you have less blood which is ejected out of the left ventricle. So, there is a problem in the relaxation of the heart. Now, if you look at adverse cardiovascular outcomes, with patients with heart failure and especially with people with diabetes, it's clearly seen that adverse cardiovascular outcomes are higher in people with diabetes as compared to non-diabetes when it comes to heart failure. But more importantly, what is seen is that this is from a sub-analysis of the CHARM study. This is seen is that the heart failure adverse outcomes, which could be sudden cardiac death, which could be hospitalization due to heart failure or an emergency visit due to heart failure, is somehow worse in patients with heart failure with preserved ejection fraction as compared to heart failure with reduced ejection fraction. Both heart failure with reduced and preserved ejection fraction have adverse cardiovascular outcomes, but preserved ejection fraction has a slightly higher HR as compared to people with heart failure with reduced ejection fraction, especially in the sub-analysis of the CHARM study. So what are the latest evidence we have when it compares to DAPA-HF and dapagliflozin in patients with heart failure with reduced ejection fraction? So when we come to the DAPA-HF study, you are trying to make use of an SGLT2 like dapagliflozin in patients with reduced ejection fraction. Now this is a path-breaking study, and it's actually done to treat patients with heart failure, and you had a huge number of patients. You had almost 4,600 patients who are followed up longitudinal, and you were adding dapagliflozin to standard of care. And what are the mechanistic advantages of an SGLT2 inhibitor like dapagliflozin in heart failure? Well, there are a lot of them. It could be the hematocrit, it could be the hemodynamic, it could be the diuretic, it could be the sodium hydrogen exchange. So there are a lot of mechanisms that makes SGLT2 like dapagliflozin very effective in heart failure, but we need evidence for it, and that's what the DAPA-HF study actually provides. It tells us that there is a 26% relative risk reduction in the combined endpoint of which is a composite of cardiovascular death or worsening of heart failure, and the number needed to treat was only 21%. There's also a 0.22% reduction. There's also a reduction in all-cause mortality, which is a p-value of 0.22. So overall, DAPA-HF, which was done in patients with diabetes, almost 45% patients with diabetes and 55% without diabetes, again proves the point that you can use dapagliflozin not in prevention, as we earlier knew after DECLARE, but also in treatment of heart failure with reduced ejection fraction. So if you look at this is a momentous, huge victory for dapagliflozin in heart failure. So we had the 4 pillars of heart failure. We had beta blockers, we had ACE plus ARB, we had the MRAs, and then we had the ARNIs. Now we have a 5th pillar, which is an SGLT2 like dapagliflozin, and this 5th pillar will make sure that it is being used in people with diabetes and people without diabetes, patients with reduced ejection fraction, patients with preserved ejection fraction as well. So thank you all for a very patient hearing. I am Dr. Rajiv Koval. I hope you all have been able to take some take-home messages and you can extrapolate it into a clinical strategy to treat patients with heart failure. We'll again come back next week with 2 other top KOLs who will probably visit another city and then talk science and also explore the city. Thank you all for a patient hearing.